Okay, so continuing our tour, now we're past the late distal convoluted tubule, and we're turning the bend again and into the cortical collecting system. This area is almost impermeable to sodium, or to urea, right? We still have aldosterone controlled sodium-potassium pumps, right? Just like we do in the early part. They're throughout the distal convoluted tubule. In this section, the type A intercalated cells are secreting hydrogen ion if needed. The type B cells can secrete bicarbonate ion if those are needed. Obviously, they wouldn't both be working at the same time, right? You know, they'd be working opposite each other. So the metabolic regulatory systems are either turn them up or turn them down. Now, this last point is probably most important, and that's in this section, permeability to water is regulatable. All right, that's a weird spot in the body. It's the only spot in the body I'm aware of where the permeability to water can be controlled by a hormone. When ADH is present, remember antidiuretic hormone is a small neuropeptide. It comes from the posterior pituitary, right? So it comes from the brain. It's released in response to changes in osmolarity, like we've talked about. Okay, when ADH is present, the distal tubule collecting system is permeable to water. When ADH is absent, it's impermeable to water. Now, the importance of this is the collecting system goes through the medulla. Okay, so if that's the kidney, and this is the cortex, okay? So you have this section in the middle, this is the medulla, okay? This has a very high osmolarity, the medulla does, right? The collecting ducts, if this is a nephron, right? The nephrons come down, up, wiggle around, and then this is the collecting system, right? Collecting system, or duct. You'll notice that the collecting duct has to pass through this region of high osmolarity, right? So if we make the collecting duct permeable to water, as this dilute urine is passing through, the water is going to get pulled out into the medulla, right? So that by the time we get urine coming out, it's a high osmolarity, just like what it passed through was. See? This is the magic of ADH. ADH opens these water channels. Let's say you're fluid overloaded. Okay, you've got too much fluid. Well, now ADH is going to be absent. Even though these tubes pass through the medulla, the water can't move. So if there's no ADH, then we have a urine that has a very low osmolarity because the medulla didn't affect it, right? Because it was impermeable as it passed through that region. That's what we're going to connect to tomorrow, okay? Is how permeability controlled by ADH is ultimately going to determine the volume of urine, all right? ADH, that's what it works on, is how much urine do you make, okay? Aldosterone works more, it works a little on how much urine do you make, but directly it's working on how much sodium is in the urine, right? ADH is the only one that doesn't need sodium to function. ADH is just a water hormone, okay? So again, more on that later. Yes, tomorrow. Okay, this area, so it's water is controlled, permeability to water is controlled by ADH. This region is permeable to urea, and that urea further increases the osmolarity of the medulla and makes it possible to concentrate our urine even more. And then finally, the collecting ducts also are, they can create a pretty substantial hydrogen ion gradient. So when patients are decidedly acidotic, like particularly if they've had acidosis for a long term, like we'll talk about on Friday, you know, like if you have a patient with COPD who has, you know, a PCO2 of 80 for 6 months, well, their medullary collecting system is going to be secreting a lot of hydrogen ions, right, in order to accommodate that increased acid load.